Dr. Chodash, I noticed that you administered a mini-cog yourself. Why did you elect to do this yourself?
Well, it's a good question. Certainly the staff can do the mini-cog, and we have trained some of our staff to do that. Sometimes I like to just do it myself, particularly where I already have some concerns, because then I get to actually see them perform. Particularly with the clock draw, I think it can be really helpful. You can see how hard are they trying, what's their frustration level, how are they trying to put things together, and you do get a little bit more information when you watch people go through the test than if you just get the results.
With the results that you got from the mini-cog, did you plan to do any further testing yourself?
Well, sometimes I do. In this case, I didn't. And the reason I didn't was because I already had a fair bit of compelling information that I knew there was a significant problem. And rather than put her through additional testing, when I knew that I wanted the consultation of a colleague, I deferred in doing that. I don't think at that point that I was really ready to make a determination. And part of my hesitancy for that particular patient was her age, and that this was an early onset disease, and that's always more difficult because it's such a significant diagnosis to give a patient. For me, I want to be absolutely sure. And so I want to have both the benefit of more detailed cognitive testing that I can't do myself, but also I want to have the support of somebody collaborating, another colleague, another expert opinion.
As far as the past medical history, the medication, the past psychiatric history, any other things that you kind of thought about to make the diagnosis or think about the diagnosis of the Alzheimer's disease?
Sure, and there were many things that weren't shown through what was on video. But we, in fact, through additional questioning, through pre-visit questionnaires, through discussions with her husband, I was able to obtain other information, and the kinds of things that I'd want to look for, just as you say, are looking for any past psychiatric diagnoses. Is this someone who had developed a depression, for example, though I certainly didn't think that she had depression? You'd certainly want to screen for that and know that depression wasn't at a minimum complicating her presentation. I think it's important to know whether there's been any history of traumatic brain injury, because certainly that'll be an important piece of information and might sway you in one direction or another. Family history is important, at least in terms of perhaps adjusting your pretest probability about whether someone has, in this case specifically, Alzheimer's disease. And then looking at other comorbid conditions is very important. Not only because you might be looking at other etiologies, like is there the possibility that there's cerebrovascular disease here, but looking at other conditions that wouldn't cause this presentation, wouldn't be the sole reason for this kind of presentation, but could certainly impact cognition and might change her presentation to some degree. So, for example, if she had significant hypothyroidism, or she was on particular medications that could potentially affect cognition, and we stopped that and treated her hypothyroidism, we might see some improvement, but we're not going to see a complete correction of what she presented with.
From the history that you gathered, it seems like you had more information that you could have shared with her during that first visit, as far as what you were thinking. Why did you choose not to do that during that visit?
So that's a really good question, and that's something I think that we all struggle with when we have certain inclinations. How much do we tell patients at that point in time? I think first and foremost, I didn't want to be wrong, and I didn't want to tell her something that then turned out to be not true, and we had just initiated this evaluation and I didn't have all the information. I could have told her that I was much more concerned and that there was a significant likelihood that she had dementia, because she was exhibiting both in her cognitive testing, even though it was really screening, and I really want to emphasize that the use of the screening tests, they're not in and of themselves diagnostic instruments. So a failed mini-cog, for example, is not equivalent with a diagnosis of dementia. But in her case, there was the reason of not having enough information to really nail this down, and it's such a devastating diagnosis to give to someone that you want to be sure that you're on pretty firm ground. And then finally, I thought that it would be unfair to leave her, even though I know she was concerned, with even more alarm, greater concern that we couldn't really close in on until we had completed the kinds of tests that we needed to do.
What kind of specialties would help you with that kind of assessment?
Well, in this case, having a good neuropsychologist,
Okay.
which is what I did, was extremely helpful, and I use neuropsychologists when that's necessary. There are many patients that I see that present very compelling stories. They are typically older, and through the other kinds of tests that we do, looking for other etiologies, I don't need to refer them at all, and I think that can be true for most primary care physicians who see older patients.
And that's important because the neuropsychology testing can actually help you diagnose but also target the management for the patients. I noticed during the first visit that you've asked her husband to come to the second visit. Why did you do that?
I really wanted him there for the second visit because I wanted to talk about the problem and I wanted to disclose the diagnosis. And I think, again, it's critically important that another family member or a close friend, if no family are available, are present at that visit, and for a number of reasons. But probably most importantly, because with any bad news, this is devastating. And to take that news yourself, it's not fair. And it's too hard to shoulder, and I think also you probably don't hear it. And you certainly don't hear anything else after that. And I wanted to be sure that there was proper follow-up and that I was leaving them with some sort of a plan. And because of her cognitive impairment as well, I wanted somebody in the room who was more likely to remember what I said.
When you disclosed the diagnosis, I liked how you talked to both the patient and the family member there. How did you get to do that in such a way that, it was so flawless and just so easy to do?
It was something that I wanted to do, and I think there's a tendency for all of us to sometimes defer or turn our attention to the person that we think is most easily able to understand us. In this case, that being her husband. But I think it's really important, one, that we don't make assumptions about what people can understand. We don't make assumptions about even what they're going to remember. And they're right there in the room, and so it's only respectful for me to put as much attention as I can on that individual, even if I'm not sure what they can understand. In addition, I think it's really important particularly when you have multiple family members in the room, as an opportunity to model behavior that this is an important person, this isn't a person we need to include in our conversations. We should never be talking about this person in front of them without talking to this person directly, because I think that's what happens to people who have dementia disorders. They withdraw because they feel less able to participate in conversations. And as a result, in part, and also because of families' misunderstanding of the condition, families withdraw and then they choose to speak to other people, and they make lots of assumptions about what their family members are able to do.
In some practices, they provide some pamphlets just to kind of prepare them that perhaps that they have this disease, not necessarily telling them this is what you have, but you can read about this and maybe even just include normal aging there or mild cognitive impairment, not just dementia, just to kind of normalize it. Do you think that would have been something that you would do? Or?
I think it's a useful thing to have in your office practice, just like lots of other informational resources for patients can be a very useful thing. In fact, when they left that second visit, that's what they left with. But I think you're absolutely right. I think what you're really talking about is educating our patient population so that they are more aware of this condition. They understand what some of the red flags are, but to the extent that we can destigmatize this,
Right.
that we can make this is something that happens to people, and you're not, you're not to be shunned, you're not going to be put off in a corner somewhere because you have some disabling condition. To the extent that we can sort of change that dialogue, is needed and would be very helpful for people like we saw during the visit today.